All right, welcome back, guys. We're going to discuss Chapter 7, Principles of Pathophysiology. We talked about a lot in the last chapter. I cannot stress how important it is as a medical provider at any level to have a good understanding of anatomy and physiology. This is going to help you with patient assessments. It's going to help you kind of identify some underlying causes of what may be going on with your patient. So make sure, pay attention, take notes. As always, try to write down any questions that you have so that we can address them in class. So some of the things we're going to talk about today, we're going to talk about the cell, the regulation of homeostasis, the cardiopulmonary system, shock, and then pathophysiology of some other systems. So pathophysiology is the study of how disease processes affect the function of the body. An understanding of pathophysiology helps you to recognize changes the patient is going through due to their injury or illness. Understanding it helps you recognize the needs of the body in its most vulnerable state. So we'll talk about the cell. So the cell has a membrane. The cell membrane protects and selectively allows water and other substances in and out of the cell. So that membrane being intact is very important. The mitochondria, the powerhouse of the cell, converts glucose and other nutrients into what's called adenosine triphosphate, ATP for short. This is fuel for cell functions. Without ATP, our body doesn't work. Without ATP, many of the cell's specialized structures cannot function. So here is a picture demonstrating different parts of a cell. All right, so cells need the correct balance of water inside and outside. So if there's not enough water, the cell dehydrates and can die. With too much water, the basic cellular function is interrupted. The water also affects the levels of electrolytes, which can impact electrical functions in our body. So on the think about it question, draw an analogy between cell metabolism and how a refinery turns crude oil into gasoline for use in automobiles. So you can kind of think of glucose and crude oil as the same thing. Steps have to happen in order to create gasoline out of crude oil. So our body has to metabolize glucose. The cell has to be able to convert that into ATP or energy for the body. So you can kind of, I'm sure there are better analogies than crude oil and gasoline, but that's what we're talking about. So glucose in the cell. Glucose is the building block for energy. The supply of insulin must match the body's glucose requirement to maintain an appropriate blood glucose level. The insulin will reduce the body's glucose level when it gets too high. So aerobic metabolism, this is cellular functions using oxygen. So this is what we want, this is what we like, it's what our body's most happy with. This is when we're not oxygen depleted. So anaerobic metabolism, this is cellular functions that are not using oxygen. This creates much less energy and much more waste. The body becomes acidic. It impairs a lot of body functions. We can function for a short amount of time during anaerobic metabolism, but it doesn't provide enough energy for sustained anaerobic metabolism. So right here we have a picture demonstrating aerobic metabolism. So we have plenty of oxygen. The oxygen and glucose is being utilized by the cell. The mitochondria is converting it into ATP. And you can see here that we are looking at 32 ATP being produced right now. So that's what is normally in aerobic metabolism being produced by one glucose molecule. So here's a picture demonstrating anaerobic metabolism. So you see we don't have enough oxygen. There's no oxygen getting down here to the cell. And if you look over here, you see that we're looking at making 2 ATP versus 32 ATP in aerobic metabolism. So when we don't have that oxygen to help us out, we're in an anaerobic metabolism state. We start to produce pyruvic acid and lactic acid as waste products, and that creates our bodies to become acidic. So the vulnerability of cells, organs, and organ systems. Many diseases alter the permeability of the membrane. Remember, we talked about that membrane is semi-permeable. It kind of allows for certain things to move in and out of the cell. But if there's a disease process that's affected that and makes it either impermeable and nothing can get in or out, or it's too permeable and it's letting everything in and out, that alters that cell's ability to function normally. So we'll talk about the regulation of homeostasis. So homeostasis is just the body's process of maintaining a stable internal environment. So homeostasis is regulated in the brain. It's maintained through the nervous system feedback and messaging. So the key structures are the hypothalamus and medulla oblongata. So we have our parasympathetic nervous system. So a lot of people call this feed or breed or rest and digest functions. So our neurotransmitters regulate digestion and reproduction. Our heart rate and blood pressure will be reduced. This is our rest and digest, feed and breed, whatever you want to call it. Parasympathetic nervous system. And then we have our sympathetic nervous system. This is our flight or fight situations. So epinephrine and norepinephrine are hormones that are increased by the body during this sympathetic nervous response. It enhances the body's ability to protect itself, but that's going to come along with an increased heart rate and increased blood pressure. All right, we'll talk about the cardiopulmonary system. So the respiratory and cardiovascular systems work together. We talked about that quite a bit in the last chapter. So it brings oxygen into the body, distributes that to cells, and then removes waste products. Any breakdown can result in system failure. So the airway here, this is the bronchial tree. So I know in the last chapter we talked about some of the airway anatomy. So up here we have our larynx, where our vocal cords are, the cricoid cartilage around the voice box, vocal cords right here. And then we have our trachea that goes down here. And just like the femoral arteries where they bifurcate from the aorta, this is the same thing. At the trachea, the bottom of the trachea is what's called the carina. That's where it bifurcates into the right and left bronchus. Sorry. And then they go down into smaller bronchioles, secondary bronchus, bronchioles, and all the way down into the alveoli, the alveolar sacs, where we will talk about here. So here's the picture demonstrating the alveoli. So depending on where you look, you'll find answers from between 300,000 and 700,000 alveoli in our lungs. You got a whole bunch of these alveoli in your lungs. These are very, very important. As we get more into kind of respiratory emergencies and things, these will be brought up a lot. But these are small sacs, have something called surfactant in them that prevents them from collapsing. You can see in the picture on the right, with the B on it, that it is encased in capillary beds. So the capillaries are there for blood exchange to happen. So when we bring fresh oxygenated air into our lungs, that capillary bed is there ready to accept that oxygenated blood and bring it to the rest of the cardiovascular system, as well as it's going to allow for carbon dioxide waste products to expel from the lungs. So you have to have an open airway for your system to function, or a patent airway. So that's very important. It's one of the first things we assess in a patient is whether or not they have a patent airway. So upper respiratory or upper airway obstructions are pretty common, caused by foreign bodies, infection, or trauma. So something like choking, or facial trauma. Something like epiglottitis would be an infection that causes the epiglottis to swell and kind of obstruct that airway. I'm not going to talk about this too much right now. This is something we'll discuss more when we get to actual respiratory emergencies and pathophysiology behind those. But positive end expiratory pressure, or PEEP. So we talked about how our lungs, the alveoli in our lungs have surfactant in them, so that at the end of an exhalation, they don't completely collapse. Sometimes we're going to have to add positive end expiratory pressure, because if we look at the little balloon on the left, you can see that's kind of deflated, right? There are some pathologies that this is going to occur, and we need to help them get more air than they're able to get. End expiratory pressure is that measurement is taken at the end of an expiration. So after somebody completely exhales, there should be a pressure that prevents those from collapsing. Sometimes we need to add more on top of what they're getting. Again, I'm not going to get too deep into it right now. All right, so we'll talk about the lungs. The lungs are part of the lower airway. So we have something called tidal volume. That is the volume of air moving in and out during each breath cycle. So when I breathe in and out, one cycle of breath, there is a volume of air that I'm bringing in and out of my lungs. That's the tidal volume. The tidal volume times the respiratory rate gives you your minute volume. So your minute volume is the amount of air moved in and out of the lungs in 1 minute. So a change in tidal volume or respiratory rate, I know it says reduces minute volume, but it depends on which way that changes, right? If my respiratory rate drops and my tidal volume drops, yes, it could reduce minute volume. If either one of those drops, but the other one stays the same, it will reduce minute volume. But if I go from where I'm at now to breathing very fast, very deep, and I increase my tidal volume and I increase my respiratory rate, then I'm going to increase my minute volume. So that slide's a little, that sentence there is a little funny. But a change in tidal volume or respiratory rate does affect your minute volume. Just depends on which way it goes. Respiratory dysfunction occurs anytime something interferes with minute volume. It could be something pretty simple like anxiety, where I'm breathing a little faster, a little deeper. Something like DKA, diabetic ketoacidosis, where I have these very fast, very deep respirations. Or it could be the other way, where I have some kind of trauma or brain bleed, where I'm not breathing very effectively, breathing slower or irregularly with a smaller tidal volume. So disruption of respiratory control. Our respirations are controlled in our brain by the medulla oblongata. Any event impacting the function of that can affect minute volume. So, infection, drugs, toxins, trauma, there's kind of a laundry list. But any of those things that impact the function of the medulla oblongata are going to disrupt our respirations. Disruption of pressure. So if a hole is created in the chest wall, the thorax, the pressures needed for breathing are disrupted. We talked about in the last chapter how our diaphragm, contracts, it pulls down and it pulls air in using negative pressure, and then it relaxes, and using positive pressure, our air is exhaled. If I have a hole in my chest wall, that pressure in my chest is disrupted, and I'm not going to be able to effectively use that negative pressure system like normal. If we have air or blood accumulating in our chest or the pleural space, that also compromises respiration. So disruption of lung tissue, trauma, or other medical problems can compromise the ability of the alveoli to exchange gas. Something like congestive heart failure. They could have fluid in the alveolar sacs. If fluid is in that space where air is supposed to be, then air can't get through. The oxygen can't get into the blood. CO2 can't get removed. If we have bronchoconstriction stuff from COPD or asthma, or like we discussed in the last couple slides, something like trauma, if I have a penetrating wound and I have actual damaged lung tissue, that's going to compromise those alveoli. So less oxygen gets in, less carbon dioxide gets out. That can result in low oxygen levels or hypoxia, and then high carbon dioxide levels, hypercapnia. Our body does a very good job to attempt to compensate for gas exchange deficits. If there's an issue, our body tries to react to it pretty quickly, automatically. We have chemoreceptors that detect changing oxygen and carbon dioxide levels. That communicates with the brain, stimulates the respiratory system to increase or decrease the rate and or tidal volume, so that we can hopefully get our pH back to normal. Our body does that all on its own. It's really interesting. All right, we'll talk about the blood. So we have four parts, four different parts of our blood. We have our plasma, the liquid part of our blood, red blood cells. That contains oxygen-carrying hemoglobin. So one hemoglobin can carry 4 oxygen molecules on it. We have our white blood cells. There's different types, but the white blood cells are there to fight infection. And then our platelets, primary function is to help form clots. All right, moving forward. So we have our plasma oncotic pressure. This sentence kind of a little messed up, but essentially the plasma oncotic pressure, it helps to maintain fluid balance between blood vessels and the surrounding tissues. Without that pressure, things could, not stay in the vessel. That pressure is very important. We have hydrostatic pressure, so that's water pushed back out of blood vessels toward the cells. And then problems with these proteins can cause an imbalance in fluid. All right, blood dysfunction. Without enough blood, oxygen and carbon dioxide cannot be properly moved around. You'll hear a lot of people talk about the ABCs. We want to treat airway, breathing, circulation in that order. Some people teach HABC. That's kind of more my style. If there's bleeding involved, big bleeding involved, we have to stop the blood loss before we can move forward with ABC, because those don't matter if they're bleeding. But it's not just bleeding. It could be dehydration. They just don't have the fluid to start with. Anemia, so a low red blood cell count. They don't have the hemoglobin to carry oxygen. Or liver failure. So here's a picture demonstrating kind of the network of how the arteries, veins, and capillaries work. So you can see that the artery here goes down into the arteriole, into the capillaries, back to a venule, and then the vein. So blood vessels. Our blood vessels take oxygenated blood from the lungs via the heart to the capillaries. The capillaries is where the gas exchange takes place between the cells and capillaries. And then it returns blood to the lungs via the heart for gas exchange to happen there between the capillaries and the alveoli. So we need an adequate pressure to make this cycle work. our blood pressure has to be adequate enough to make it happen. Our pressure is controlled by changing diameter of blood vessels. So there are stretch receptors that monitor the pressure, and that pressure can be increased or decreased depending on the situation. So we'll talk about some blood vessel dysfunction. We have loss of tone, so the vessels just lose the ability to constrict and dilate. If that occurs, our pressure is likely going to drop. Things like trauma, infection, allergic reaction, those are going to cause us to lose vessel tone. And we'll talk about that a little deeper when we get into shock. Here's a picture demonstrating that. So we have a normal vessel right here, and then we have a dilated vessel. When those vessels dilate, we have excessive permeability. Remember in the last chapter we talked about at the capillary beds, those capillaries are only one cell wall thick, so they're very thin to allow things to move in and out of the capillaries. When we have widespread vasodilation, we have all these vessels dilating, the space between those cells gets further apart, and now some of that plasma, some of that liquid can leak out of the vessels and just into what's called the interstitial space, kind of just into the tissues, and that will cause edema or swelling. It can be caused by severe infection called sepsis, high altitude, several other disease processes. So right here's a picture demonstrating that permeable capillary. They're just, those cell walls are already thin, and once they start stretching, it allows them to be pretty permeable. We have hypertension. So there's something called systemic vascular resistance. That's the pressure inside the vessels. Again, we need some of that. Too much or too little is not good. Various conditions can lead to abnormal constriction of the vessels, leading to an unhealthy high blood pressure. It is a huge risk factor for stroke and heart disease. So hypertension, that's a big risk factor. Then we have just a loss of regulation. So chemical messengers tell the blood vessels when to dilate and constrict, and if those signals are blocked, problems can arise. So there's just a lack of sympathetic response, and that can cause shock. Again, we'll kind of talk about this in a little bit more depth when we get to shock later in this chapter. All right, the heart. So you can think of the heart as the pump, and this will all start to make sense here in just a little bit. So as a pump with an average stroke volume or output of about 70 milliliters per contraction. So a normal healthy adult heart is pushing out about 70 milliliters out of the left ventricle into the body every time it contracts. So the stroke volume is based on the preload. The preload is the amount of blood returning to the heart. Contractility, so just how hard the heart is squeezing, and then the afterload, which is the pressure the heart has to pump against to force the blood out of the system. So our stroke volume, that volume that's getting pushed out of our heart with every beat, times how many times a minute our heart is beating, gives us something called cardiac output. So if our heart rate slows or if our stroke volume decreases, then our cardiac output will be decreased, and the opposite is true. If our heart starts beating quicker and our stroke volume remains the same, then our cardiac output will increase. A very fast heart rate will reduce cardiac output because there's not enough time between contractions for the heart to fill. So our stroke volume has no choice but to decrease. There's just not enough blood. There's not enough time for the heart to refill with blood. So over time, your stroke volume gets a little less and a little less and a little less. So pediatric compensation. when it comes to infants and young children, the heart rate is very important. If they start to become hypoperfused, if their oxygen level starts to drop, you'll see that change in their heart rate before you see it in any of their other vital signs. They lack a lot of the contractile muscles. Their heart can't really regulate the force of contraction like it can in an adult. And a fast heart rate is going to indicate compensation. They're doing what they can to compensate for whatever's going on. So heart dysfunction, there's some mechanical problems that can happen, like physical trauma, squeezing forces, or cell death or heart attack. And then there are electrical problems, damage to the heart's electrical system, and those can cause unorganized rhythms and rate problems. So to put it all together, the entire cardiopulmonary system has to work together to maintain life. There has to be a balance between ventilation and perfusion, so what they call the VQ match. But there has to be that balance between ventilation and perfusion for the system to work properly. That VQ ratio can be disrupted by any challenge to either one of the cardiovascular system components or a respiratory system component. All right, now we're going to get into shock. So perfusion, that is the regular delivery of oxygen and nutrients to the cells and then removal of waste products. That's where our body's happy. That's what we want. Hypoperfusion or low perfusion. Shock can be summed up into inadequate perfusion. There's some kind of a breakdown in the system and it can result in the death of the patient. So it's 4 different categories of shock. So there's hypovolemic, so just a low blood volume. That can be from excessive blood or fluid loss. It does not have to be just blood. Somebody who's just extremely dehydrated, especially in a short amount of time, can experience hypovolemic shock. Distributive, so there's a low blood vessel tone. There's 3 little subcategories here. So anaphylactic shock, allergic reaction that continues and progresses into shock, anaphylactic shock, septic shock, and neurogenic shock. So those 3 all fall under distributive. Neurogenic shock sticks out a little more. When we start talking about trauma later in the class, we'll talk about it a little bit more. I'm gonna come back to that one. We have cardiogenic shock, so the heart fails to pump. And then obstructive, the blood cannot flow. So I think about this kind of as we have our pump, our heart, we have our pipes, the vessels, we have the tank, which is just the volume of fluid that we have in our body. And then obviously there can be a clog that happens in those pipes. So hypovolemic shock, there's a problem where our volume is just too low. We've lost volume and now we cannot perfuse because we don't even have the volume in the tank. For distributive, we have that volume, but now all of our pipes have gotten larger. So it takes a lot more pressure to move that fluid throughout the pipes. But we can't because our pipes are just expanded too much. Cardiogenic, so our heart fails to pump, something like a heart attack. Imagine if the fuel pump goes out in your car. You got gas in the tank, but the pump is broken and it cannot move the gas from the tank to the pump or whatever. And then there's obstructive. There's some kind of an obstruction in the pipes that will not allow blood to flow. We'll talk a little bit about, we talked about hypovolemic shock could be fluid loss or blood loss, something like a massive bleed or, pretty sudden volume loss, like I haven't been drinking and I've had vomiting and diarrhea for 2 days and I haven't replenished any of those fluids. Or I just had a large cut or something that's allowed me to lose a lot of blood in a short amount of time. Distributive. So anaphylactic shock, we talked about that's an allergic reaction that's progressed into anaphylactic shock. Our body's just really overcompensated for that allergen in our body. Septic shock is kind of a widespread, full body infection essentially, similar to anaphylactic shock in certain ways where our body overreacts to the dangerous things that are within our blood. We're going to skip neurogenic shock for a second. It's the same thing. It's going to cause those vessels to dilate, and that's going to cause us to lose pressure and not be able to perfuse. It's a little bit different in one way. So in all these other shocks, normally you're going to see that they become tachycardic. Their heart rate starts to increase. And normally they will be like pale, sweaty, cool skin. But in neurogenic shock, you will normally see a normal or even low heart rate because there's a true insult neurologically, and your body cannot compensate like it tries to in the other shocks. Cardiogenic, so something like a heart attack, you have a myocardial infarction, you have cell death in the tissue of the heart, and it just cannot pump the same. And then obstructive would be something like a pulmonary embolism, where I'm pumping blood out of my heart and it's supposed to go through my lungs, but all these vessels inside my lungs are clogged up from those clots in my lungs. So there's an obstruction that causes shock. Hopefully that clears the mud for some of you. This was a really hard concept for me to grasp in EMT school. All right, recognizing compensation. So, when problems come up, our body attempts to compensate. So signs of compensated shock are slight mental status changes, increased heart rate, increased respiratory rate. You may have a delayed capillary refill time, pale, cool, clammy skin, and sweating. So we already talked about most of these shocks. Our body attempts to compensate in these ways. So if I have volume loss or there's an issue with my tank, my pumps, whatever, it's going to try to compensate for that loss of pressure by increasing my heart rate and trying to get that blood moving around. The reason we have things like delayed capillary refill time and the cool, pale, clammy skin is because our body is trying to shunt blood, it's trying to move blood from our extremities to our core, where all of our vital organs need the blood more than our hands, right? So our peripheral vasculature, all of the veins and arteries and everything in our extremities are going to try to constrict and reduce the blood flow to the extremities so that we can keep it in the core. Because of this, you're also probably not going to have a very strong peripheral pulse or distal pulse. So decompensated shock occurs when the compensatory measures fail. So just like the anaerobic metabolism thing, we can do it for so long, but at some point those systems will fail. This is characterized by decreased blood pressure and altered mental status. The reason their mental status is altered is because the brain requires a certain pressure to be perfused. So when our blood pressure drops below that, we become altered. Irreversible shock occurs when inadequately perfused organ systems begin to die. Some of the things like our kidneys, our heart, our brain, it does not take very long, between about 4 minutes to maybe 12 to 15 minutes of no perfusion before those organs are dead. All right, we'll talk about the pathophysiology of some other body systems. So fluid balance. Our bodies is about 60% water. Out of the water that's in our body, about 70% of it is intracellular, 5% is intravascular, and then 25% is interstitial. That's just the space between everything. So our brain and kidneys regulate thirst and elimination of excess fluid. As long as everything's functioning correctly, our brain and kidneys do a great job of fluid regulation. Blood plasma proteins pull fluid into the bloodstream, and our cell membrane and capillary permeability regulate flow in and out. So disruptions of fluid balance, we have fluid loss or dehydration, where we just have a decrease in the total water volume. And then poor fluid distribution. So water is not getting where it needs to go. We talked about that excessive permeability. Edema, that's swelling associated with the movement of water. You'll see this in patients with like heart failure, where there's congestive heart failure, there's extra pressure, makes it hard for the body to feed blood back to the heart. That causes a little bit of backflow of the blood. And so you'll see this edema, it's gravity, wherever the gravity is. So if this patient is somebody who's normally sitting in a chair, you're going to see a lot of swelling in their lower extremities, in their feet, ankles. Sometimes it's all the way up into their thighs. But if the patient's bedbound, that is going to be a little harder to see because it's going to be all along their back, and it's a little harder to assess. The nervous system, so our brain and spinal cord, those are very well protected by bone and muscle. It's covered by several protective layers called meninges and a layer of shock-absorbing fluid, the cerebrospinal fluid. That being said, it's still subject to damage from trauma or disease. So you could have a traumatic incident that damages your spinal cord, or you could have disease like meningitis, where you have inflammation of the meninges. There's several things that can insult the nervous system. So nervous system dysfunction of trauma can be from anything. They list motor vehicle crashes, falls, diving accidents. But in this field of work, you're going to see all kinds of wild things, but traumatic injuries can cause nervous system dysfunction. And then there's some medical dysfunction like strokes, infection like meningitis or encephalitis, disease like Lou Gehrig's disease, multiple sclerosis or MS, or even low blood sugar, hypoglycemia. All right, so the endocrine system has glands that secrete hormones. These hormones send chemical messages to the body to control body functions. The major organs of the endocrine system: the brain, kidneys, pancreas, pituitary gland, thyroid gland, and adrenal glands. Again, I'm going to share some videos with you guys that I found very helpful. They're maybe a little overkill, but it made a lot of sense to me. So endocrine system dysfunction. So it can be an organ or a gland problem. It could be something that's occurred as a result of illness, or it could have been something present at birth. There are things where there are too many hormones, something like Graves' disease, where we have too much thyroid hormone that causes problems with our heart rate and temperature regulation. Or something where there's not enough hormones, like type 1 diabetes, where our pancreas is not secreting insulin. So our body cannot regulate blood glucose levels, and we have to supply it with insulin. Adrenal insufficiency. So this affects steroid hormones, the steroid hormones cortisol and aldosterone. So medications that suppress the immune system suppress adrenal function. And something like adrenal insufficiency can result if patients stop taking their prescribed steroids. Their body's not producing these steroids, or not enough of them, so they're on medications to help with that. And if they stop, this could get even worse. The digestive system, so it allows food, water, and other nutrients to enter the body. Major organs of the system are the esophagus, stomach, and intestines. So digestive dysfunction, that's going to impact hydration levels and nutrient transfer. So It can be several things. Gastrointestinal bleeding, that can be slow or it can be quicker. They may have a known slower chronic bleed, but can also be massive, can present with rectal bleeding or and or vomiting blood. Vomiting and diarrhea. These are very common disorders. There's a variety of underlying causes, and it can result in malnutrition and dehydration. Our immune system is responsible for fighting infection. It responds to specific body invaders by identifying them, marking them, and then destroying them. Again, these videos that I'm going to share with you here in a little bit, they will hopefully make this make a little more sense. All right, an allergic reaction. So this is a hypersensitivity issue. So there's an allergic reaction to certain food, drug, or other substances, and it's the result of an exaggerated immune response. And the chemicals that respond to this affect more than just the invader. There's a lot of byproducts that happen, and we'll probably get into that a little deeper in person in class. That allergic reaction produces edema. We talked about when an allergic reaction progresses and turns into an anaphylactic shock, there's a lot of steps that happen in this process, but it's a form of distributive shock, right? Where our vessels dilate. When our vessels dilate, our capillaries become permeable. It allows fluid to escape. So we will have edema. A lot of times in an allergic reaction, we see that in the tongue or around the mouth or in the hands. It can result in a rapid drop in blood pressure because our vessels are suddenly dilating, and it can be very life-threatening, which is why it's very important for us to identify this early and treat it how we can. All right, chapter review. So pathophysiology allows us to understand how negative forces impact the normal function of the body. Helps us understand how common disorders cause changes in our bodies. Understanding how the body compensates for insults kind of gives us an idea on the signs and symptoms that we see during an assessment. Understanding what compensation looks like helps us identify potentially life-threatening problems. All right, some things to remember. Cellular metabolism requires a constant supply of oxygen and glucose. Absence of either one of those components disrupts normal metabolism. Our cardiopulmonary system combines the functions of the respiratory and cardiovascular systems to provide oxygen at the cellular level. Shock, that occurs when the pulmonary system fails and the cells become hypoperfused. The body is composed primarily of water, and this fluid is distributed throughout the body systems. All right, there's chapter 7. Again, go through this, take notes, bring them to class. Any of the questions you have, happy to answer. Thanks. See you on the next one.